Good morning and welcome to the first webinar in our Perinatal Addictions Prevention Seminar series, Focus on the Facts, What Science Teaches Us About Alcohol, Vaping, and Marijuana. Our webinar today is entitled The Hidden Epidemic, Intellectual and Developmental Disabilities Resulting from Social Drinking. My name is Amy Gohl, the Director of Education for the Partnership for Maternal and Child Health of Northern New Jersey. The partnership is providing today's program. A few pieces of information before we get started. About an hour after the webinar ends, you will receive an email with a link to a post-program evaluation. Please complete the survey to provide us with feedback on the program. To receive a certificate of completion, you must listen to the entire webinar and complete the evaluation survey. Be sure to note on your survey if you would like CABC or nursing credits. Certificates of completion will be sent via email within 1 week of the webinar broadcast. This program is being recorded and will be available on the partnership's YouTube channel until June 2nd, 2022. We will be muting all attendees' microphones during the presentation, but we would love to hear from you. Please write questions in the question box, and the speaker will address them either during the program or at the conclusion of the presentation. And now I would like to introduce Rachel Ugranovsky, the Partnership's Perinatal Addiction Prevention Specialist, to tell you a little bit about our speaker.
Good morning. Thank you so much, Amy. Thank you, everybody, for joining us. So a little bit about Sharon. While working towards her bachelor's degree of science in biology from Northeastern University in 1989, Sharon Boyer-Levine worked for the Division of Human Genetics at the University of Connecticut School of Medicine as a teratogen information specialist with the Connecticut Pregnancy Exposure Information Service, CPEIS. Upon obtaining her master's degree of human genetics from Sarah Lawrence College in 1991, Sharon's role became prenatal genetic counselor. Becoming the coordinator in 1998, the service evolved into what is currently known as MotherToBaby Connecticut and was an original member of the Organization of Teratology Information Specialists, OTIS. Sharon has been a member of OTIS since 1991 and has held various positions there, including president. In addition to genetic counseling, Sharon is a mentor and an educator to medical and dental students, obstetric and pediatric residents, genetic and maternal and fetal medicine fellows at institutions such as Sarah Lawrence College, Boston University, and University of Connecticut. Her passion for this work continues through her numerous publications in the field of teratology, along with countless educational outreach services to both the general public and healthcare providers. Sharon has been like a mentor to me. I reached out to her upon starting my work in this field for education, guidance, and support. Besides her expertise, her patience and ability to teach complex information has helped me thrive in my ability to feel confident in educating others. And needless to say, she has tremendously impacted my career by that alone. So I present to you Sharon Boyer-Levine.
Thank you, Rachel. I'd like to thank Rachel and the team for inviting me to give a talk about something that unfortunately we're still talking a lot about. Today we're going to focus a little bit less on the actual full-blown fetal alcohol syndrome and talk more about when there's a little bit less than the heavy drinking in pregnancy and get a little bit more immersed in those details. So today the talk is intellectual and developmental disabilities resulting from social drinking. The disclaimers here, we don't have any conflicts of interest, no commercial support. I think Amy also spoke to you about the continuing education piece, what you need to do, and how long this website will be available. Okay, so today we're going to identify what the spectrum is, what the fetal alcohol spectrum disorders includes. We're going to understand how FASD can occur and what the potential outcomes might be for the child, and recognize the possible different outcomes that are related to low and moderate prenatal consumption of alcohol. So first things first, I'm a genetic counselor, so we have to remember that there's never a free ride. So there's always a chance when a woman gets pregnant that she could have a baby with a birth defect. There's always that risk. So for every 100 babies that are born, 3 to 4 of them are going to be born with a birth defect. 10% of those birth defects are going to be caused by what we call teratogens. That's a fancy word, just means an exposure in pregnancy caused the outcome. So that 3 to 4 per 1,000 babies are going to have a birth defect that's related to some kind of outside impact. So whenever I'm counseling patients, I have to remind them that even if you lived in a glass bottle for 9 months, you're not guaranteed perfection. So I think that's something that we all need to remember, the background risk. Now, we're talking about alcohol. So what do we know about women and drinking? In 2012, the CDC had this behavioral risk factor surveillance system, and they discovered that in pregnant women, almost 8% reported drinking alcohol in the past 30 days. And that even included almost 2% that were binge drinking, and they counted binge drinking as greater than or equal to 4 drinks per occasion. So that's pregnant women, women who are already pregnant. In non-pregnant women of childbearing age, about 50% are consuming alcohol, and 15% are binge drinking. And I know I'm preaching to the choir here, but remember that about 50% of all pregnancies are unplanned. So if you're not actively trying to conceive, not thinking that you might become pregnant, you're in this non-pregnant category, and about 50% of those women are drinking. That's a lot of potential exposure. Some more data here, 24% of women in the ages of 18 to 24 binge drink, averaging 6 drinks at one sitting. And we're going to talk about what a drink actually equals. Hospitalizations for alcohol overdoses. This is a situation where women are catching up to men and not a situation we want them to. In that same age range, the hospitalization for overdose jumped 50% between 1999 and 2009. And for young men, the rise was only 8%. So women are drinking. So what is a drink? And I think this is a good education for all of us, because if we were all together, we could go around the room and I'd ask different people what they thought a drink was, and we might all come up with slightly different answers. So a drink, for definition, is a 12-ounce beer versus 4 to 5 ounces of wine versus 1 to 2 ounces of hard liquor. Now, when we're out at a bar or a restaurant, we're more likely going to get more of a metered drink. So we always ask patients, are you home when you're drinking? Are you out when you're drinking? Because when you're at home, you might grab any receptacle that's close to you to fill with alcohol. And so, you're not measuring out a 12-ounce beer or a 1.5 ounce of alcohol. You're mixing by yourself. The other thing is, nowadays when you go to a restaurant or a bar and you get a beer, you get a 16-ounce pint. You get a pint. So already that one drink is more than one drink. So I always ask people about their drinking habits in terms of home or away. I ask them, size. What size beer did you get? Because of course there's the 3-foot version of them now, a yardstick of beer. What was it, a mixed drink? Long Island iced tea, I think, has at least 4 shots in it. So that's 4 drinks in one glass. So, I try to narrow things down as best as I can using the measurement of what a drink would be. Okay, so how much alcohol is too much? It's not known if there's a safe amount that can be consumed at any time in pregnancy. That's the tricky part. That's the sticking point that gets us confused over and over again. And we're going to talk through a lot of that today. So I'm sure you're well versed on what the spectrum of effects are with prenatal alcohol exposure. The full-blown fetal alcohol syndrome, which is encompassing characteristics that include the face, growth, brain, and behavior. Partial fetal alcohol syndrome, which would encompass cognition and behavior and either face or growth issues. The alcohol-related neurodevelopmental disorder. So I know we over the years, we have morphed into so many different terms, but right now the ARND, alcohol encompasses alcohol exposure with brain or cognition issues. And then the neurodevelopmental disorder, prenatal alcohol exposure definition includes alcohol exposure, brain issues, behavior, and adaptive conditions. Okay. Just quickly reviewing what fetal alcohol syndrome encompasses. Again, the characteristic features are listed here for you. Some of the terms, which, growth issues, small head, small body, developmental delay, average IQ 63. Remember, those of you in the audience, your average IQ is probably well over 100. So someone with an average IQ of 63 is pretty impaired. They can have fine motor function dysfunction, the facial features, the short palpebral fissures, long smooth philtrum, thin vermilion border, 50% have heart defects, and then the mild to severe joint contractures can also be present. This is a quick review for you for the face. The epicanthal folds are those folds in the corner of the eye. The palpebral fissure is the distance between the inner and the outer opening of the eye. Short upturned nose, smooth philtrum is under the nose, between the nose and the upper lip. Now, these are kids that most of us, unless we're in the business, are not going to look twice at on the street. These are kids that don't look so unusual that they make us wonder what's going on with them. Here's a picture of a girl who aged through the years. I think you can see her distance between the eyes is wider. I always feel like her eyes look pretty big, but if we measure them, the eye openings are smaller. She has a smooth philtrum, scooped out nasal bridge. The epicanthal folds are pretty prominent there, and I don't really appreciate her thin upper lip until she's smiling in the bottom picture. And again, I think if we just saw this picture of a child, we might not say she looks unusual, truly. Okay? And of course, she has genetic features like her mom and dad as well. Okay, so what time in pregnancy is the fetus most vulnerable? Well, guess what? All trimesters of pregnancy are a potential risk for the baby. And this is a schematic that I pull that I use, and I actually use this when I'm counseling patients so that I can explain to them that the yellow portion is prior to when the organ systems start to form. So that's when the egg and sperm come together, all the cells are rapidly dividing, the embryo is implanting into the uterus, developing the blood connection, and then right then at the red section is when all the sort of critical stages of development for most of the organ systems start. And the organ systems are listed. You'll see that the brain starts first, and it never ends. It's always forming, even after the child is born. The heart is short and sweet, starts at about, and the weeks listed at the top are the age of the embryo. And in prenatal, we count pregnancy from the first day of the last menstrual period. So heart starts at about 4.5 weeks from the first day of the last period. It's critically done by 8 weeks, totally done by 10. So if you haven't had an exposure in that time frame, you're not going to have an increased risk for heart defects from whatever it is that you were exposed to. I hope that makes sense to people. And the other organ systems are listed there, but pretty much the first 12 or 14 weeks are when all those organ systems are being put together. And the remainder time in the pregnancy, the brain is still forming, of course, central nervous system is still going on, but everything is pretty much growing. We're thinking about the placental function. We're thinking about premature delivery, things like that, more so than, how is the heart doing? Because whatever's happened with the heart, whatever's happened with, limbs and things like that, it's done. It's done. And exposures later on are not going to go back and undo anything that was done correctly either. Okay. All right. So how high is the risk? Well, with alcohol exposure in the first trimester, we think there's a risk of miscarriage of about 15 to 50%. Now, general population's risk is about 15 to 20%. for any pregnancy. So it is higher, but it also overlaps that background rate. The risk for minor changes in the face is 10 to 15%, and the risk for a heart defect is about 8 to 10%, when in the general population, the risk for a heart defect is about 1.5 to 1%. So it's definitely higher. Yeah, I'll apologize for the cats in the background. Sorry, everybody. Apparently they don't like what I'm talking about. Okay. So the heart defects is almost 10 times, up to 10 times the background rate for heart defect if you're drinking. And again, what time would you have to be drinking for the heart to be affected is that weeks 4 to 10. Okay. Second trimester, remember I said organs are done, so we're worried about brain and growth. And so there can be growth delay if mom is still drinking. And there's a 5 to 25% risk for learning disabilities and behavioral problems because, of course, the brain is still forming. Okay, dose. So this is the crux of the problem. More is worse. That's easy to figure out, but to tease out the nuances of each one are a little bit trickier. So we consider chronic heavy alcohol to be 5 or more drinks per day. So someone who's drinking heavily like that throughout a pregnancy still has about a 2 to 8% risk to have a baby with fetal alcohol syndrome. So that gives you a little bit of a marker to what less drinking might entail. So even in someone who's drinking heavily, there's still the greatest likelihood is their child is not going to have fetal alcohol syndrome, but most certainly will have some problems on the spectrum. Binge drinking is 4 or more drinks, and we say in about 2 hours. I usually say per occasion. I always ask people, were you at a picnic or you're at a wedding, so you drank over 8 hours. That's a little bit different than someone who's just going out for the evening for like 3 or 4 hours and consuming, 5 or 6 or 7 drinks. Moderate drinking is even trickier. That we define as more than 2 drinks a week, which I think probably many of us in the audience could say we do, up to 2 drinks per day. That's a big range, okay? That includes a lot of individuals. And then the other or the low or the, what's left is someone who's drinking 2 or less drinks per week. Okay, so dose is important, very important, but makes it tricky for studying. So to give you an idea of what's out there, I could have listed all the references and the authors and what the findings were, but I thought that would bog us down. So instead I made this table so that we could compare and contrast. And just to give you the feel for how much is really out there. And this is the tip of the iceberg. I, of course, did not include every study that's out there. I included in this slide specifically the studies that actually came up with a negative outcome linked to drinking low to moderate alcohol exposure in pregnancy, just to give you a sense of what's out there. So for example, the first study suggested there was an increase in the risk for heart defects, and the dose that reported in that study was 2 to 3 drinks per day. Okay. Another study looked at, I think it found leukemia, and the drinks were 4+ drinks per month. Another study found an IQ drop of 5 to 7 points, which, on the grand scheme of things, isn't that much. But if you're somebody who already is going to be an individual that has a lower IQ to begin with, 5 to 7 points could be quite a bit. And that was 3 drinks a day. The spelling and reading challenges, individuals have difficulty with that. We saw anywhere between a study that said 3 drinks a day to 1 drink a day. Craniofacial defects, those are the things, the facial issues. Cleft lip and palate is one of the ones that they're looking at there. And that was one study that just recorded it as being low levels of drinking, whatever their definition of that was. And another study that said greater than or equal to 1 drink per week. Okay. So as low as 1 drink per week. Congenital diaphragmatic hernia is a situation where the diaphragm has basically a hole in it. It hasn't formed properly. And so the contents of the gut below the diaphragm herniate up into the chest. And that is a problem because the lungs can't form properly, the heart can be affected. That's a serious serious birth defect. And studies that suggested that were one that said 5 or more drinks, one that said 1 to 3 drinks per occasion, and another study that said 1 to 4 times per week. Okay. And I threw in one there, miscarriage and stillbirth. So pregnancy loss was one study that suggested moderate drinking was linked to that. Another study that said 3 or more binges or 2 or more binges. So I think when we look at this table, we see A, there's a lot of different outcomes, and B, the doses are all over the place. And why is that? So there's a lot of reasons. One is every one of these studies has a flaw, has some flaws to how it's designed. It's just the way nature is. We cannot take a group of women and take them and expose them to alcohol at metered amounts, all the same, and compare them to a group of women we don't do that to. We just can't do that. So we have to do observational research, which means it's either prospective or retrospective. Prospective means we're asking women questions throughout the course of their pregnancy, keeping tabs on what they're doing, how much alcohol they're consuming, in what manner, what other exposures are they having, and comparing those to women who aren't exposed to alcohol. Retrospective is after the fact, going back maybe 3 years after they gave birth to try to ask some questions. Now, I don't know about you, but I have trouble remembering what I did yesterday. Never mind, I have 3 children, ask me what I did in my first trimester with my oldest. I'm never going to remember that. So there are a lot of bias in terms of what information we're going to get back. People tend to remember bad things more than good things. So they might remember, oh yeah, I didn't know I was pregnant and I was at a wedding and I remember I drank, and I remember that, but they might not remember how much they were having sporadically or in between all of that. So they remember a holiday party or some sort of event, but not remember the details. So those are some of the flaws that we can see. What people are counting, what the researchers are counting as a drink could be flawed. What women say. I know in your work, I'm used to somewhat considering that whatever they're telling me, I might want to double, because they may feel comfortable telling me they have a drink 3 times a week, but not comfortable telling me that it's more like 5 times a week. If they're out drinking at a party, they might say, I had 3 drinks, when in fact, really, it was closer to 6. So there is some leeway in terms of what women are going to feel comfortable exposing themselves. And letting us know what's really going on. So again, those confounding factors make it very difficult to study drugs and alcohol in pregnancy, because it's not an exact science. We know more is worse. That's easy. The hard part is there a threshold? And the best way that I can explain the threshold from a genetic counselor's point of view is there's a genetic component to which individuals are going to express an adverse event as related to alcohol exposure. And there's environmental components, and the environment can be the alcohol exposure, but it can also be, maybe mom's placenta's not functioning properly. Maybe she's on other medications. Maybe her metabolism has changed because she has some kidney damage. So there are other non-genetic or environmental factors that play a role. And then the dose of how much alcohol plays a role, and the timing. So all of those factors together kind of have to line up in a certain way to get a certain outcome. And that may be different for different individuals. Everyone metabolizes alcohol differently. Every fetus is going to metabolize it differently. What the fetus inherited from both mom and dad in terms of genetic load for being affected by alcohol is going to be different. Even if you have the same mom and she's drinking the same amount in subsequent pregnancies, each child could be affected in a different way or not affected, right? So the genetic pieces I never want us to forget about, because that's something we can't control and we don't know enough about. Is there a gene that predisposes a child for fetal alcohol spectrum disorder? Probably not a single gene. Probably a multiple genes, or a cascade effect, where if one gene is not functioning properly, the genes that follow after it that would be important are interrupted in such a way that leads to an adverse outcome. So there is a lot to this picture, and a lot that we don't know, and we may never know for sure. One more study I wanted to bring out was this light to moderate consumption study, and they said even below 1 drink per day. So they saw problems with central nervous system, sleep disturbances, mood effects, memory, learning, attention, executive functioning disorders, behavior, and permanent growth delay. All these things overlap what we see in fetal alcohol spectrum disorder. So, not that every child had every one of these things, but they were seeing some effect. The other issue when we're talking about exposures that I always like to think about, and so when you work with addiction, I'm sure you think about it as well, is people may be drinking to self-medicate. And so they're drinking to alter their own behaviors and their own mood. And so they may actually have those conditions themselves that they've passed on to their child, and that their child's outcome is somewhat related to their genetics, not so much the alcohol exposure. And that gets really difficult to tease out as well. So when I'm counseling prospective adoptive families on, what might they expect if a birth mom was using alcohol in pregnancy, I have to remind them, or not even alcohol, if she's using drugs too, is that maybe mom is trying to counteract some symptoms that she has herself, whether it's ADHD or OCD or depression, that she's trying to treat that with the drugs and the alcohol. And that just because the child has a similar condition doesn't mean that the alcohol or the drugs caused it. It was more of a genetic consequence. Okay, so let's refresh our memory what the neurobehavioral disorder involves in terms of neurocognitive impairment, self-regulating impairment, and adaptive functioning deficits, because we said even in the low to moderate categories, we may be seeing some of these. Neurocognitive impairment, the poor executive functioning ability, I think that's the one that really affects all aspects of that individual. So that's your ability to sort of multitask, to get things done. I used to use my son as a good example. Day 1 of school, all the folders and notebooks, everything's nice and neat. By day 2 or 3, the social studies work is in the math folder. The math, who knows where that went? There's things that are missing. So the ability to keep things organized and keep things together. Learning impairment, so they have usually have some need for some special education or some special intervention. Memory is another thing that can affect everything that they do. You could teach them some vocabulary words one day, and the next day it's like you didn't teach it at all in the worst case scenarios. Visually and spatially challenged, that would be drawings, not being able to recreate a drawing on their own piece of paper by following what's been written on the board, for example. Lining up numbers for math, so addition and subtraction when you're adding 2 or 3 digit numbers, that can be difficult for them. The self-regulatory impairment, so difficulty regulating mood or behavior. They can't wait their turn. They have impaired impulse control. Attention deficit, lots of people have that already, but to stay focused on something for a long period of time is very difficult. The adaptive functioning deficit, so they learn to speak later. Their verbal communication is slower. They can have awkward social skills. A lot of times that may make us think of the autism spectrum disorder. They have difficulty with basic life skills, so learning to bathe, body taking care of themselves. And then motor function delays. If you think about what the contractors mean, it means that their joints are stiff or locked in place. And if you can't have full range of motion of your joints, you're going to have, you're not going to be so good or so fluid with your motor function, your gross motor function or your fine motor function. And so things like running, skipping, hopping, jumping, you may be clumsy at and learn later. The no understanding of consequences, that's true for all children right through the teen years and maybe our young adults as well. But for example, when I was giving this talk to prospective adoptive families, I gave the example of a child on the top bunk decides they're going to jump down onto the floor and not think about that, yes, they could get hurt, they could break something, they could land on somebody else. They're not thinking about that. And a mom says, well, my daughter does that, but she puts pillows all over the floor. So I go, well, she is aware of the consequence then. She is aware that she could get hurt. And that's why she's softening the blow by putting pillows down. So it's not even thinking about that, or, not remembering to look both ways to cross the street, not remembering to put their helmet on when they're riding their bike. The difficulty reading social cues and appropriate behavior. So standing in somebody's personal bubble. We all have that personal bubble around us, and there's only certain people in our lives that we let invade that bubble, right? So someone I've just met, I'm not going to speak to them right, 2 inches from my face. We're going to have a certain amount of distance between us. But these kids, they don't understand that, and they may be right up in somebody's face talking with them, and that other child may step back and they may step forward thinking, why are you moving away from me? And you can imagine any or all of the previous criteria, the issues that we talked about already, can affect relationships with family and friends, because you're not always going to go around saying, hey, my son has these specific issues, so you don't want to behave this way with him, or he may behave that way with you. You just don't do that kind of preface every time you meet individuals. People have to learn what others are like in order to get along with them. But these are kids that can be quite challenging. So now not only do we have a newborn or an infant or a child that we're concerned about, but these kids grow up. So what does the prenatal exposure, how does it manifest at the different ages? And even with low to moderate alcohol, we can see some of the developmental issues. So from the birth to 3-year range, kids can have poor immune function. So they're getting chronic ear infections, upper respiratory infections. They might have medical issues related to birth defects. So if they had a heart defect or they have the contractures, they may have had surgeries or physical therapies and things like that maybe put them behind in their motor skills and their learning. They're also really lousy sleepers, generally speaking, which makes it difficult for parents and the other individuals in the home. And so the referrals that are usually being made in that time frame are, in Connecticut, we have birth to 3 or 0 to 3 programs. So there's early intervention programs probably in every state. They might want to be seen by an ear, nose, and throat specialist, and many are seen by sleep specialists, even in the birth to 3-year range. The preschool to school age these kids continue to be lousy sleepers, and that's tough on the whole family and tough on the kid, because if they can't get restorative sleep, their behaviors are going to be somewhat amplified on subsequent days. We begin to see for sure, all young children have a certain degree of attention deficit hyperactivity disorder, but truly to diagnose it when we see it in the preschool to school age, when they really should be settling down and they're not. The referrals at this stage might include the neuropsychologist, which actually I took my own son to, and it's a lot of testing. And for someone with ADHD, you got to go on multiple days, because there's no way a kid can get through it in a single day. But they look at the whole picture of the child and talk about what their strengths are and how to build on those, and what their weaknesses are and how they might remediate those. Family-based therapy is always a good idea. occupational therapy, speech therapy. And then once you're into the school situation, the IEPs, the individual education plans, or 504 plans. And again, those are things parents have to ask for. The school doesn't volunteer them because those mean that those kids are going to cost them more money than they would in the regular classroom. So those are things that parents really need to be coached on how to ask for. In the adolescent years, now we're looking at higher risk for substance use. And again, they may want to be self-medicating for their own behaviors. Risk of injury and poor decision-making skills. That's a general category for adolescents, of course. Mental illness might start to appear at that age, and they can also have inappropriate sexual behaviors. And those referrals continue to be psych, housing, working supports, disability, applications, and the continued individual education plan. Even a child that goes on to secondary education, goes on to college, is eligible for those types of supports as well.
Sharon, excuse me, this is Amy. We do have a question from the audience.
Excellent.
The question is from Susan, and she's asking, do all children with FAS have behavioral or learning disabilities and also low IQs affecting schoolwork needed and IEP managed by the CST?
Do all children with FASDs? So it's a spectrum, right? So there are going to be some kids that are of normal IQ, of course, and there are going to be some kids that don't need special interventions for cognition. And there are going to be some kids that just need behavioral supports. So there is no all or none situation, I would say. It's a mixed bag. And again, that makes it very difficult to tease out who's been impacted by alcohol and how do we support them. Does that answer the question?
She actually, Susan just sent in a clarification. She actually wants to know about the students with the FAS facial features, such as a thin upper lip, etc. So do the children who are displaying the facial features have behavioral or learning disabilities and also the low IQs?
The face is to us a clue as to how the brain has formed. That's how I learned it. And so someone with the facial features can certainly be someone that has brain issues. If you forgive me for a minute, I can go back to the slide where we outlined that right here. So if you look at this slide, you'll see that cognition is a piece of every part of the spectrum. Behavior is 3 out of the 4. The face is only the first 2. So if you've got facial features, then you're going to have either the full-blown FAS or partial FAS. Does that help clarify that? And if you do have that, you're going to have cognition issues and behavior issues. But I can't say that every case will be a child who's, in the mental retardation range. They could still be in the normal range of IQ, but perhaps on the low end of normal.
Thank you.
Does that help?
I haven't gotten any more comments, so I think that does.
Okay. All right, so forgive me for flashing through these. Okay. So we talked about full-blown fetal alcohol syndrome. We talked about using the dose of alcohol and why that matters. We talked about the studies and how they aim to get us more. And I gave you the tip of the iceberg, and I only showed you the studies that actually came up with problems. There are thousands of studies, and I don't know if there's thousands in a year, but there are hundreds every year of research reports that are done on alcohol exposure. And if we include animal studies, there's even more. We're trying to figure out why alcohol does what it does. And is there a way to predict that it might happen? And is there a way to fix it? If someone says, you know, I used and now I'm not, is there something we can do differently in the remainder of the pregnancy to make the outcome better? There are studies looking at that. And there are reports out there for every report I showed that has found an adverse event is related to the alcohol. There are studies that show that the same amount of alcohol has not caused an adverse event. So that brings us back to what I was demonstrating earlier, to the genetics, the environment, the dose, and the timing. All are playing a role in what individuals are going to be affected and who's not. And when we do a study, we want to see the outcome, the adverse outcome occurring at a greater frequency than it would occur in the general population. Remember, we said there's that background risk for birth defects. For example, the heart risk for birth defects is 0.5 to 1%. If we're studying heart defects and alcohol, we need to see that the women who used alcohol had babies with heart defects at a greater incidence than that 0.5 to 1% of the population to be able to say that the alcohol played a role. So how often is this happening? And there's been some really good research lately on this. So remember this study where we talked about pregnant women and how much they drink, and non-pregnant women drink a way lot more. And so there's definitely going to be, you know, with that 50% of unplanned pregnancies going in there, and maybe even higher than 50% in certain populations, that we're going to definitely have kids exposed in pregnancy. So the first data that I have here, the CDC did their fetal alcohol syndrome surveillance network, and they came up with 0.2 to 1.5 cases per 1,000 births of the full FAS. And they estimated that FASD rate was at least 3 times that, okay? And that makes sense because there are going to be more women who drink less, and less is not safe necessarily. And there was this other study of first grade students, and they used a representative Midwestern community, and they found that FAS occurred in 6 to 9 per 1,000. The partial FAS was 11 to 17 per 1,000 births, and the overall rate was, wow, 24 to 48 per 1,000, which is 2.4 to 4.8%. That's almost 5% of that entire population had some effects from alcohol exposure. That's a lot of people. And then if we look at kids in foster care, then the numbers go up even higher because we know that's a greater at-risk population there to begin with. And many of them are undiagnosed. They're labeled as bad kids or troubled, and so on and so forth, and don't really get the interventions that they deserve. So we've been studying this a little bit more and more recently. The group that published this article in 2018, a lot of those individuals are members of the Otis organization, and they looked at the prevalence of fetal alcohol spectrum disorders in 4 US communities, and they picked rural versus, you know, private schools, public schools, rural communities, urban communities. And this made the headline news. As many as 1 in 20 US kids harmed by alcohol in the womb, study says, and that was a CNN report. So it made the headline news. Bad news makes the news, you know that. And the only good thing about this is, you know, alcohol exposed pregnancy is totally preventable. And if we educate individuals better about it, we're going to have better outcomes. So here's what the study found. 1 in 20 children may fall in the FAS spectrum, suggesting that what we thought prior were underestimates. 2 of 222 identified students at least 4 sites had been diagnosed previously. So we're not diagnosing them. We're missing them for various and sundry reasons that our medical professionals aren't necessarily trained. There's bias. So here in Connecticut, Farmington, Connecticut is where the Yukon Health Center is, and that's kind of a well-to-do, well-educated community versus, like, say, an inner city in New Haven or Bridgeport. If a physician is caring for a patient in both of those cities, he may be more likely to consider drug or alcohol use in the inner city mom versus the urban, the rural, more rural suburban mom who's well-to-do, right? So we have biases that are wrong. We should be treating everybody the same and screening everyone the same. Students were ascertained in the first grade classes. 60% of the group agreed to participate. So the ones that didn't agree to participate, or the parents refused participation, why? Is there something to hide? Were they concerned they would be found out? You know, there's some issues there. And they used the new criteria for diagnoses, which I'm not going to really go into for our purposes because I'm not really sure that any of us in this group are actually going to be diagnosing FAS, but more or less recognizing that it's a possibility and maybe remembering some of these features so that if we are seeing them, we might ask some additional questions of our parents. They had the cross-sectional study of 13,151 first grade children in 4 regions of the United States, and they surveyed them from 2010 to 2016. The most conservative prevalence estimate for FASD ranged from 11.3 to 50 per thousand, so that's 1 to 5%. And when they used a weighted approach, the estimated prevalence now went to 3 to 9.8%. Okay, so this means to me that women are still drinking. They're not all drinking to such an excess that the FAS is resulting, but in fact the FASDs are resulting, and we're missing those. We're not screening our pregnant moms universally. We're in screening, I don't mean drug testing them, I mean asking the right questions and following up if we need to. We're not educating our general population well enough for them to understand. I know if you pick up a bottle of alcohol these days, isn't there a picture of a pregnant woman with a line through it? Or there's verbiage saying don't drink while you're pregnant. But we can also turn on the news, or we can see people on social media, television, who are drinking when they're pregnant or told by their doctors still to this day that a glass of wine now and again is not a problem. And my problem with that statement is, first of all, you don't know how mom's going to interpret that. Oh, my doctor said I can have a glass of wine now and again. Okay, well, how much alcohol? How much alcohol is in that glass, for one? And if a glass of wine is okay now and again, then maybe once a day is okay, right? Or maybe 2 glasses now and again is okay. And how does he know that mom doesn't already have a problem and he's given her permission to kind of continue to drink? So that's a slippery slope when we say it's okay. If someone comes to me and says, I was drinking a glass of wine with dinner 3 nights a week, and when I found out I was pregnant, I stopped. I am not going to alarm her, but I am going to congratulate her on acknowledging that that's something that she should discontinue, and support her in not continuing to do that. It's just so much safer to not. And this slide is prenatal alcohol. None is still best, and the low to moderate is tricky, and it is a slippery slope in terms of what we're able to tease out, what we know is a problem, and what we can be sure is a problem are different things. I said it before, this is not an exact science. It's not something simple and straightforward where we can say, yes, 3 drinks in a week is going to cause a problem, but 2 drinks isn't. We'll probably never get to that because of all the reasons we talked about today. The MotherToBaby Connecticut, I just wanted to let you know, if you're in New Jersey, you will get our service in Connecticut answering your questions. Anywhere in the United States that does not have their own service in their state, we divvy those states out. So if you call, the 800 numbers for Connecticut only residents, but the other number you can reach out. Right now with the pandemic going on, we're working from home. So the way to reach me is through the email there, mothertobaby@uchc.edu. And we can give an individualized risk assessment. So today we've talked in general But if there's an individual that you feel needs to hear the information, or you feel you want to talk through the scenario with someone like myself, where we can sort of pinpoint as best we can what we know might be happening, what testing in pregnancy might be offered, to provide that patient, that person with some additional information about how the baby's doing. We can look for heart defects. We can look at growth. We can look at the structure and formation of the brain. And if we see a problem, we can be more concerned. But if we see that everything looks like it's where it's supposed to be and doing what it's supposed to be doing, it still could be a child with mental retardation and issues. So there are things that we could talk about. You can also find us online, MotherToBaby.org, our website. Our national website has a fact sheet on alcohol. There are baby blogs, there are podcasts, there's a lot of really good information. There's a whole maternal mental health section there, and there's a whole hot topic section on maternal opiate use in pregnancy, since I'm talking to the addiction folks. So those are also resources for you to use to not only educate yourself, but to help you better help the people that you're working with. Okay. I think I mentioned to Rachel and Amy before that I talk fast, so I raced through those slides, and I'm happy to take questions now about anything that we talked about so far.
Thank you so much, Sharon. That was terrific. A reminder to those who are on the call that the question box is still open, so please feel free to continue to submit your questions. I think Rachel has some questions already to start, so I will let her begin our session.
Okay, great. Thank you, Amy. And thank you, Sharon. That was absolutely wonderful. So the first question I have, fetal alcohol spectrum disorders, can they only be diagnosed at birth? Yes or no? Why or why not?
Okay, so at birth, the things that we might notice if we're looking carefully are perhaps some of the facial features. The growth, certainly a child that's not grown well or has small head, small body is going to be noticed. But most of the other features are not going to be noticeable. So it's probably a little less likely to diagnose at birth than it is to diagnose as a child is growing and developing. And that may set up the situation where we're missing somebody, right? So if we didn't know mom was using alcohol, we might not even be thinking about that at all. So I think more kids are picked up later than earlier.
Okay.
Thank you.
I'm sorry, I have something in addition to that. With that in mind, we record, we do keep statistics in New Jersey about, babies born with fetal alcohol syndrome, and you can adjust birth records up until the first year. What if somebody is diagnosed with FAS or another spectrum disorder after you can adjust the birth records? That would mean that they're not taken into account in the overall statistics of kids exposed. And so how do we really know how to help and how many kids essentially have fetal alcohol spectrum disorder because of that?
I think that's a good question. It's a good point. I'm not even really sure what we do in Connecticut about that, and how much further down the road can you actually amend a record. The only other way would be with sort of the studies that we've done to collect that kind of information more universally. And at some point, we may be set up in such a way that we can do that. But you're absolutely right. There's a flaw in the system in terms of keeping track of these records.
That was a really interesting question, Rachel. Thank you. So I have another question coming in from Dana, and she wants to know if it's possible to have the facial features of FAS, but a child with a high IQ, but who has social difficulties.
I would say that's possible. Let's go back to that sort of definition slide again. You can still see my desktop, right?
Yes.
Okay. So we're saying a child with facial features, but still have a high IQ, but have behavioral issues.
Correct.
Correct? Okay. So having a high IQ doesn't always equate to, well, I'm not sure I know the exact answer, but here's how I would think through that. You can be bright, very bright, right? And be smart in math, but not so good in reading or writing or something like, some other aspect of things. So you may still have some challenges in your thought process, the way that your brain works. And I'm not sure how high an IQ you're talking about. So if you're talking about in the normal range, yes. If you're talking about a child who is way above average, I'm not sure that we could still call them FAS or PFAS, that they might be more in one of the other two categories.
Thank you. Rachel, did you have another question?
I think the other thing I wanted to say is that if this is confusing, you're getting it. Okay, if it's not clear and straightforward to you and it seems like it's confusing, you're absolutely on point and you understand what I'm trying to convey, that this is difficult. It's difficult to talk to patients about it because you don't really have good answers for them all the time. Genetics in general has a lot of gray areas, and this is one of them.
Okay, thank you. Are the adverse effects seen in children who are prenatally exposed to alcohol unique to alcohol exposure?
So all of those neurodevelopmental features that we talked about, all the learning and behavior, are things that can happen to anybody. So you can have a child that has attention deficit. You can have a child with an executive functioning issue. You can have a child that so there is no one hallmark feature in the neurodevelopmental piece that makes us think, only alcohol can do that. Therefore, alcohol was part of this puzzle. So again, that's part of what makes it so confusing and difficult to tease out, is that this overlaps general population issues.
Oh, I just wanted to mention that we have a lot of great comments coming in about how much people have enjoyed the webinar. I do have another question from Carol. Are there studies that look at the father's drinking behavior?
Yes, there are. I left that out intentionally because if you think this is confusing, that's more confusing, I think. To try to figure out, generally in genetics, what we say, if an agent can't alter the genetic material in the sperm, then it shouldn't increase the risk for birth defects for a child fathered by that sperm. But there are studies that look at, dad's drinking and potential adverse outcomes. And they have found links, but are they true links or not? And if dad's drinking again, I always wonder, is mom drinking too? And that's confounding the whole scenario. So yes, there are. And you can go and you can Google and you can pull up hundreds of those. Generally speaking, I don't focus a whole lot on dad's use. I want to know more socially, like, and why is he drinking? Does he have a mental health issue that he's self-medicating that he may pass on the genetic predisposition for to this child? Is his drinking or drug use impacting her life in any way? Is she safe? Is she newly clean? And the fact that he's using in front of her make her more at risk to relapse. Those are the things I think about with dad drinking. right or wrong, that's what my focus is in those situations.
Thank you.
Great. I'm glad. I should have put in at least one slide about Dad, but somebody always asks me, so thank you.
Okay, are we ready for another question?
Yes.
Okay, so who can diagnose fetal alcohol spectrum disorders?
Well, that's another tricky question. Realistically, any medical professional should be able to. Now, I work in a medical school, and I can tell you there isn't really a training session on how to diagnose FAS. Pediatricians should be aware of it. Obstetricians should be thinking that, you know, screening moms as potential risk, but really it should be pediatricians, developmental pediatricians. There's a whole clinic in Connecticut that's just focused on fetal alcohol spectrum disorders. And so that clinician, that's all she does. But you're going to find those kinds of people few and far between. Geneticists, pediatric geneticists, are often the ones, and the developmental pediatricians are also often the ones that end up making those types of diagnoses. Dr. Kenneth Lyons-Jones is a dysmorphologist, a geneticist, and he's the individual who discovered fetal alcohol syndrome back in the 70s. He is a member of Otis, our organization, has been a mentor to me. So he is somebody, obviously, who, you know, I wouldn't say, but can do it in his sleep. But there aren't that many people out there that are highly skilled at that. So that makes it difficult for parents who are trying to tease out what's going on with my kid. But I would always divert to a geneticist, because you're going to have at least one of those in every state. The bigger states hopefully have more. We're doing more and more remote now that we have the pandemic going on. Even in our department, we're seeing patients on video, but trying to get the care out to them so that those diagnoses can be made. Our juvenile detention centers and our prisons are full of individuals with FASD that just didn't get the interventions that they needed and were misdiagnosed.
Here's a question
Okay.
coming in from Erica. Is there a link between FAS and autism?
They can overlap, yeah. You can see from the list of all the behaviors that we talked about, you know, the not understanding consequences, the not buying into sort of social norms, social cues, those overlap with autism. You can, I would say you can have both. Just like a child with Down syndrome can have Down syndrome and have autism. I don't know that we would say that autism is part of the syndrome, but I think you can have both. And some children might actually have been diagnosed with autism when in fact the real underlying etiology of their condition was alcohol exposure in pregnancy. I can imagine that happens often.
Okay, with that being said, Sharon, what are some of the other misdiagnoses that, you know, somebody could have been given as opposed to, you know, one of the spectrum disorders?
Well, I think any of the neurobehavioral issues, a lot of times, you know, in genetics, we have what we call our unknown file, where we have seen a child, we don't know what's going on with them, and we stash them away in hopes that at some point in the future, something will come up that fits. And I think a lot of these kids are in that unknown file, because if you don't know about the alcohol, mom doesn't admit to it, if it's not asked about, if it's a child that's been put up for adoption or put in foster care and that information is not available, we may never put the pieces together. So a lot of the kids will just have the diagnosis of behavioral issues, or they have attention deficit disorder, or they may be labeled as autistic. They may be labeled, I hate to say it, but some kids are just, oh, that's a difficult child. That's all. That's the answer. Which, we're failing miserably with those kids in that scenario. And I'm also, there are probably many other genetic disorders that can have features that overlap with this. Individuals who have taken anticonvulsants in pregnancy, seizure medications can be used to treat seizures, mood disorders, pain, migraines. Those kids can have, in some instances, the facial features of fetal alcohol syndrome. And so they may be thinking of it's medicine, but medicine usually, moms are going to cop to. Oh yeah, I took Tegretol, or yeah, I took Depakote. They're going to actually admit to that because it was a medication, not a drug.
So Sharon, what's the best way to support parents of children with FASD?
Well, I think when we went through the years, birth to adolescence, and the different supports or referral systems are there, helping them navigate the system is the best thing we can do in terms of what referrals are there? How do I find a neuropsychologist? Is there in-home services that are available that I can access? Help them access anything and everything they can through their school and their town or their state. What is out there that's free? I think, those of us who are nurses, social workers who work, are adept at working the system, that's what we need to do, is to help those parents speak up and advocate for their child. That's the best thing you can do. Empower them to help, get all the supports they possibly can.
Okay. What about all of the kids that grow up to be adults that have been misdiagnosed? And we know that, if you get the wrong diagnosis and your symptoms are a result of alcohol, that the treatment doesn't usually work. So now we have, like you were saying, in detention centers and then prisons, a lot of people that have been exposed to alcohol, and they just, sort of come out and repeat that cycle and are in and out of treatment and other types of systems. How do we begin to help, or how do we help them identify that they've been exposed to alcohol, if we talk about the older population rather than the younger population that are still with their parents?
So our teens and our young adults and even our older adults who've been missed all this time can still be diagnosed, and they can still, get supports, but they have to get diagnosed. And I think we need to work better as a society either from an entry point when someone's coming in to try to figure that piece out, or when they're being released. Is there a process through which we can further identify through healthcare, psych or healthcare, to determine, do they carry this diagnosis? Again, we really stink at diagnosing this. As you can see from that recent study, that we're missed, like 2 out of 222 kids that actually had a diagnosis were picked up, and that was only a fraction of our general population. Those were those kids in school, and until the education piece is filtered through all the different aspects of our society, we're not really going to solve that problem. So if you're working with individuals in foster care, if you're working with individuals in detentions, in detention centers or in prisons, that keep the alcohol on the radar and think about, was this ever talked about? Was this ever screened for? Can we get them an evaluation that might come to that conclusion, because then they're eligible for other supports.
Right.
I have a question from Lisbeth. Is there a disproportionate rate of children with FAS in relationship to race or ethnicity?
I don't know off the top of my head the answer precisely to that, but what I can say is that we know alcoholism rates in our Native Americans are greater. So our Native American population may have a disproportionate amount of individuals who have FASD. I think of our socioeconomic levels in terms of, I hate to say that, rich people don't drink to excess, and that's not true. But for race, I think the disproportionate piece may be to their access to healthcare and interventions as well. So unfortunately, I don't know that number or that statistic off the top of my head. I would venture to say yes, but it may also be a fact that we haven't really looked at the big picture well enough to know the answer to that yet. If we're not looking for it, we're not going to see it. And if we're only looking for it in our inner cities or in our minorities, we're going to find it. It's going to skew the data. Great question.
Thank you. I have one that just came in from Patricia. How do you talk to a parent about the effects of alcohol exposure without isolating them?
Well, what do you mean by isolating them? Making them feel bad about it, or?
I would go with that, and then maybe Patricia can type in the question box if that's not what she had intended.
Well, listen, nobody says when they're a kid, I'm going to grow up to be an alcoholic. I'm going to grow up to drink too much. I'm going to grow up to be somebody who didn't know better to not drink in pregnancy. Nobody wants to be an addict, right? So, I'm always focused on whatever positive piece I can. So if it's they found out they were drinking and they stopped midway in pregnancy, fantastic. That's better than drinking throughout the entire pregnancy. So focus on that. If they cut back their drinking, we do this with smokers too. If they were drinking heavily in the beginning and they weren't able to stop entirely, but they slowed down, well, that's to their advantage as well. They're bringing their child in for care now. Someone who didn't really care about their child's well-being wouldn't bother to do that. They're trying to find ways to help their child. So I try to support as much as the positive aspects of their behaviors as I can. We're not shaming them. We're not belittling them. We're not scolding them. There were states, I think Kentucky and Tennessee, who made it a crime to use alcohol in pregnancy. And so, what happened is women stopped asking their doctors for help. They weren't going to go to the doctor, for one, so they weren't getting prenatal care. And two, they weren't going to fess up to, yeah, I've been drinking, because they were going to get thrown in jail. So that just doesn't work. Absolutely doesn't work. So we need to, congratulate them for actually having the courage to ask for assistance.
What is the best way to educate teachers and school personnel on how to deal with children with FASD in the classroom?
Excellent question. Another area that we really are lousy in. Teachers need to know a lot, right? They need to know a lot about their students. In my personal experience with my kids and their learning issues, I found that what the administration knew about my kids, the teachers didn't always know. And so they're like, well, we don't tell the teachers because it's confidential. And my argument was, well, how the heck are they supposed to help my kid if they don't know what their challenges are? And so other than what they see on the testing, the tests. So I would, then reach out to the teachers to say, here's the situation, here's what's going on, here's what you need to know about my kid. So we need a little bit more open discussion in that sense, but teachers need trainings. They need to understand that sometimes the skills that they've learned to deal with kids with the challenges such as, the cognitive challenges or the behavioral challenges aren't always going to fit with a kid who's been exposed to alcohol. And everyone learns differently. I still don't think we're good at that. I think teachers have a lot to handle, but I think we're still not great in that aspect. So any kind of training, something like, this kind of talk so they can hear what it's about. Special ed teachers are better at it, but they still don't get the training that they could use as well.
Thank you. And I know our perinatal addictions prevention project team does go out to schools and provide that kind of education. I agree with you that it's
that's excellent. If it's not on the radar, and they've got so much else to be concerned with, they're not going to think about it. So education is key, absolutely key. And when I talk about, I talked about how we're diagnosing these things, and in medical school, we're not teaching it. So it's pervasive. It's all the way at the top for the physicians that aren't learning it. The nurses don't get enough education on it. Daycare providers, everyone that comes in contact with a child who's growing and developing should have some sense of what this is about.
I couldn't agree more. I have a question about, I know you talked about that your team can provide individual risk assessments. I have a question about, can we detect brain damage in an ultrasound?
Okay, so when we do a scan, ultrasounds aren't perfect. They can't tell us everything that we want to know about a baby, but we do look at the size of the skull. So we look at the bone. Is the skull the size that it should be? Is the brain, there are different pieces to the brain. We look at those, cerebellum, cerebrum, things like that. Are they in the right place? Do they appear to be the right size for the gestational age? Sometimes we're going to see that that's not the case, that either the brain is the wrong size, that some pieces are bigger or smaller, that there are cysts in the brain that would show up, fluid-filled cysts or solid masses. There are things that we can see. Certainly we can't tell, is every neuron firing in the way that it's supposed to be? Is all the brain tissue normal? We can't see those, but we can't do that for anyone either. So, I have patients who come in who had alcohol exposure and they want to know, is my baby's brain okay? Well, so does everybody. But the problem, we can't give them any more detail. We can't see autism on ultrasound. We can't see mental retardation per se on ultrasound, unless, like I said, there's really a physical or morphological difference in how that baby's brain is looking on the ultrasound.
Thank you. I have another question. Is there a known amount of alcohol and a known gestational age where risk is greatest to the fetus? I think I might know the answer to that one myself, but
okay. So first trimester, when all the organ systems are starting, that is going to be the highest risk period, because if you think about it like domino effects, if you damage a cell early on in the stages of development, every cell that was going to come from that cell is now either not going to be formed or going to be formed improperly. So the cascade effect from that point on, that is going to be damaged. So first trimester, I would say, is the greatest period of risk in terms of that. But second and third trimester, you know, the central nervous system is still forming. If a person, for some unusual reason, starts drinking late in pregnancy, we still could see effects on the brain. Probably just not as much as if they had started the drinking early on. And as for dose, I can't say there's a dose that I would say is safe or unsafe. I can't. So really all trimesters are a risk, but the greatest risk I still am going to consider is early on. So a lot of times patients call and like, oh, I didn't know I was pregnant. I was at a holiday party and I haven't had anything to drink since I found I was pregnant. Those pregnancies, those babies are going to do better than the ones who maybe didn't find out they were pregnant until they were 4 or 5 months and had been drinking throughout the pregnancy, or those who are unable to stop. But anytime we stop, anytime we cut back, is going to be better for the baby. And that's probably as best as we can say. Is that what you were going to say, Amy?
Probably not in as much detail, but I think I got the general idea.
Yeah, so first trimester, and we don't know the dose. More is worse is as best we can say.
I think that's a great, very thorough answer and a great way to wrap up our webinar today. I want to thank you, Sharon, for giving such a great presentation and spending all this time answering the questions that came in. I also want to thank everybody on the call who attended, and to Laura Hall, who's handling the technical back end of the program, and of course to my co-host, Rachel Ugranovsky. A reminder that in about an hour, you'll receive an email with a link to a post-program evaluation. Your feedback is very important to us, so please take the time to complete. Certificates of completion will be sent via the email you provide on the evaluation, so please be sure to double check that what you enter is correct. You should receive those emails within 1 week. And again, a reminder to please be sure to note if you require CADC or nursing credits. I want to mention that our webinar series will continue next week. On June 11th, we will have vaping, finding your way through the cloud, and that will be followed on June 17th with a talk, Are We Going to Pot? Links to these programs, as well as a calendar of the partnerships upcoming virtual programs, can be found on our website, which is www.partnershipmch.org under the Professional Education tab. We also offer on-demand recordings of many of our programs, and they will also be listed on that webpage as well. Thank you again for joining us, and we hope that you can come again to our next educational event. Thank you.